Good afternoon. My name is Carlo Martuscelli, and I'm a health policy reporter for Politico Europe. Today, I'll be moderating this session titled Delivering EU Health Equity, a 2030 Ambition. Fresh out the grips of a once-in-a-century pandemic, Europe is facing down the barrel of twin economic and energy crises this winter. Health systems are pushed to the limit as doctors and nurses withdraw from the profession in unprecedented numbers. Once again, it's the continent's most vulnerable who will bear the brunt of the crisis. The elderly, the poor, the homeless, people living with disabilities, migrants, sex workers, they risk going cold and hungry, and it's their health that is most at stake. But in times of crisis, there is opportunity. This year's team at Gastein is the Health Union. And it was at the height of the pandemic 2 years ago that the European Commission laid the foundation for its Health Union. It launched a package of measures to upgrade and expand the EU's health infrastructure. These, the cancer plan, the health data space, and coming soon, the pharmaceutical strategy, represent an unprecedented effort to level up healthcare provision across the bloc. If it works, it will set the foundations for a healthier, more equal union. So now, even as we keep one eye on the unfolding crisis, we must look ahead. The UN Sustainable Development Goals set out a range of targets that we should aim to reach in 2030. Goal 3 is ensure healthy lives and promote well-being for all at all ages. Goal number 10 is to reduce inequality within and among countries. We've brought together a panel of experts across the worlds of government, academia, industry, and civil society. In the company of these experts, we will discuss the present crisis and future opportunities. I'd like to thank Porter Novelli Health, who have organized and delivered this session. And joining us today, we have Michael Marmot, Professor of Epidemiology at University College London. We have Caroline Costings, Director of EuroHealthNet. We have Isabel Della Matta, Principal Advisor for Health and Crises at DG Sante. We have Alexandra Thomas, Director of Public Affairs at FPIA. We have Enka Toma, Executive Director of EPF. And we have Ricardo Baptista, a Member of Parliament for Portugal. Dennis Onyango of Nobody Left Behind and Programs Director at African Advocacy Foundation. Generally, I like to encourage a lively discussion between the panelists, so please don't wait for me to intervene, respond to one another. Let's make this as dynamic and lively as possible. And I'm afraid to say audience participation is also essential. So to everyone here and to our friends watching from home, please don't be shy. And if you ask a question, I'll be sure to put it to the panelists. So it's also an opportunity for you. I'm going to kick things off with a brief 5-minute one-on-one interview with Professor Michael Marmot. Thank you for joining us today, Michael. Yes, there he is.
My pleasure.
Hello. You're an absolute expert in the field of health equity. In a few words, can you tell us what is Europe facing this winter and who will be the worst affected?
We've had 3 challenges to health equity in recent times. The first, in the wake of the global financial crisis, was a decade of austerity that was pursued to different degrees in many countries. The second is the pandemic, which exaggerated and exposed the underlying inequalities in health and in society. And now the cost of living crisis, which will do the same, which will expose and amplify the inequalities in society. And all countries across Europe are facing this cost of living crisis to varying degrees.
Michael, sorry, can I just interrupt you? You said all countries across Europe, but I was wondering, should we be differentiating between different countries? The UK in particular, we've had the IMF say yesterday that their fiscal measures are going to worsen inequality. So can you talk a little bit about that?
Yeah, it's a disaster, an absolute disaster. It shows what happens when you let evidence-blind ideologues free into decision making. The evidence is very clear that if you want to get economic growth, tax cutting is not the way to do it. The IMF has shown that, economists have shown that this myth of supply-side economics is a myth. And it's a complete myth. And we've got a set of ideologues who believe in the market, and the market passed judgment on their policies while the Minister of Finance was delivering his speech last Friday. This has never happened. While he was delivering his speech, the value of the pound dropped. The markets delivered their verdict. We don't think that these free market ideologues should be let loose on the British economy. And then unprecedented, think of the criticism of the IMF over the decades of their commitment to neoliberalism. And the IMF comes in and says tax cutting at a time of economic crisis is bad for the economy and will increase inequality.
Michael,
and that's what the budget will do.
The markets have given their verdict, but in practical terms, which sections of the population will be most affected? And I don't mean just in the UK, also across Europe.
Well, the problem is this could be infectious. That what happens in the UK, it's the fifth or sixth biggest economy globally, and what happens in the UK can be infectious. It can spread across Europe, and that's a real worry. So, as some of you will know, I've for decades now been pointing to the social gradient in health, that poor health for the poor is a big issue, but where you are in the social hierarchy has a big impact on health. Now, what we've seen before last Friday's disastrous budget, what we saw was in the UK, more than 60% of the population were facing fuel poverty this winter. 60%. This is not just the very poor. This is the gradient. People in the middle, so asked who will suffer. People in the middle, the poor will suffer because of the decline in investment in services, particularly healthcare, but other public services. But people in the middle will suffer when youngsters who have just bought a house and suddenly find their mortgage payments going up. So they're not the very poorest, but they're trying to make it economically. And they find that there's no good childcare services available at affordable rates. Everyone is going to suffer, except for the top 1% who were the grateful recipients of the Minister of Finance's tax cutting.
A very fast final question for our one-on-one, which is obviously the negatives here are overwhelming, but I wanted to know, are there any positives in terms of recovering state capacity? We've seen the state intervene in energy to try and offer a little bit of relief. Might we see the state intervene in other areas that affect health equity?
Well, the problem, let me briefly say two things. One is the state intervened to freeze energy prices in the short term. And that's very welcome for people who are literally going to shiver and starve this winter because of inflation, the price of energy, and the price of food. So that's very welcome. I don't like the way they did it, and the IMF criticized the way they did it, but at least they did it. But the other side, we know what's coming. We know what's coming. It's called starving the beast. the next time the Chancellor stands up, he's going to say, well, because we've got these big debts, we're going to have to cut public services further.
Great.
We've had a decade of austerity, and of course, the poorer you are, the more you need public services. And the next thing he's going to say is, because I cut taxes, now I'm going to have to cut services. And that will have an adverse impact on people who are disadvantaged.
Okay, thank you, Michael. We're going to bring you back in a second to join our panel discussion. But before I do that, I did want to put a poll for the audience, both in the room and online. The poll is, what are the key factors driving health inequalities in your member states? This is a word cloud. For the online audience, poll responses, comments, and questions can be submitted via Slido, which is found next to the stream on the conference platform. For the people in the audience in the room, you can go to slido.com and use the keyword Luna or scan the QR codes which are on the screens up here and to the side over there. If I can ask the panelists to join me up here, we have, together with Michael, we have Isabella De La Mata, Ankatoma, Dennis Onyengo, if you wouldn't mind joining me on stage. Thank you. Okay, so we're getting our first answers and well, to back up Michael's point, we have austerity right there in the middle. I see interest rates, energy prices, a lot of macroeconomic factors that seem to impact health, which is quite the divergence from the pandemic, where obviously it was a virus. Do you have any of the, I'll open up the discussion for the panelists. Do you have any thoughts on these? And do you have microphones over there? Here. Isabel, do you have a microphone? And could you have thoughts on social determinants, which is right in the middle there?
I got a chance to type it in before coming to this.
Okay. Grading your own homework.
It was the one I could type. Yeah, health inequalities are influenced by social determinants, such as education, job status, income, type of job, also age, also the environment that we grow, social mobility, if you want. So it is definitely something, but it's a snowball effect. What I find really alarming when we talk about the perma crisis is that it really is a snowball effect, and every little disaster leads to a bigger disaster. And it's really concerning in terms of equity in health. Mm-hmm. And for that, I'll put it to you, there's something that I really believe in. There's a quote from Thomas Jefferson: "There is nothing more unequal than the equal treatment of unequal people." And austerity, because we have it here, it's one of these sort of equal treatments, cuts across, right. But who suffers most, it's those who already were suffering, because they're even worse off, and that we can't afford to have.
So we're going to definitely return to this theme, both of austerity, and I heard the word perma-crisis, which I'm sure I'm not the only one where this hasn't been the first time you've heard that word this conference. But before we return to that, Dennis, I wanted to turn to you, actually. As a representative of civil society, we've been talking about the big picture macroeconomic situation, but you're close to where all of this is playing out with the people that are on the front lines of things like austerity. What's your role in tackling health inequality, and where do you see the biggest challenges, both this winter, but even looking ahead to 2030?
So thank you, Carlo, for that question. As you know, I'm representing NLO, which is Nobody Left Outside Initiative, a collective of organizations that are working with some of Europe's most underserved populations in terms of health. And health inequalities, of course, are very pronounced, or can I say, quite challenging for the communities that we work with. We see systems in Europe that are not geared towards supporting those who are vulnerable, who are in the margins of society. And by that I mean the homeless people, migrants, sex workers, LGBT people, prison populations. And what I think is that we have situations, or can I say systems, that really do not understand the needs of communities. As a collective of organizations, what we want to do is to be able to bring these voices to the fore, and to be able to challenge policymakers to have, equity-centered kind of policies.
So what is an equity-centered policy?
So I think these are having clear KPIs that look at how health systems operate and how they treat those ones who are vulnerable in society.
So targets.
Targets, yes. And of course, it's really a shame that, if you look, for example, in Europe, on the case of migrants, for example, around 14 countries in Europe, and some of these are member states, some of the very high economies, test migrants, for example, for infectious diseases, but do not offer treatment for those who are undocumented. I mean, that's a shame. And if it was it's even unethical, and if it was happening for populations that were not in the margins of society, there would be an outcry.
Right.
How do you really justify that you can actually screen people but deny them treatment? So I think that what we're trying to do in the community is to be able to highlight some of these gaps and to ensure that health systems are responsive to the needs of communities.
Do you find that you have enough data to do that? Is there good quality information about these? This is a loaded question. I see you asking, I see you laughing, but I'll throw it to you.
No, I think that's a really perfect question. We were looking at the ECDC surveillance system, and they have a register of 50 infectious diseases. And out of these, they were saying, for example, that they can only analyze and make sense of the data that they have on 2 diseases, which is HIV and TB. And then you ask yourself, how do you, plan for healthcare when you don't even have information?
Right.
And I think that this challenge of data is something that we've seen over time. And I think that health systems need to be able to capture data properly. Health institutions need to capture data and be able to interpret it properly for policy making.
So I'm going to take that and I'm going to pass that question to Isabel. We know that data is on the Commission's mind of late. We've had the European Health Data Space legislative proposal, but what is the European Commission doing in terms of its programs to address health inequalities, both with data but beyond that as well?
In the European Commission, first we have the framework that is the European Pillar of Social Rights. And we have also a commissioner that has in her mandate the equality in the European Union. This is general, it's not just for health, but on health we have been working in an horizontal way for many years with the member states, the joint action on health inequalities. And we continue to do that, for example, now with the cancer, with the European Beating Cancer Plan, and with the European Cancer Inequality Registry that is already going on, has already been launched at the beginning of the year in February, and that is under the Joint Research Center, and that we have already some data. They are available in their website, but that we will continue with reports, different reports in the even and in the odd years. Yeah.
Do you think, so on the Cancer Inequality Registry, I think that's been greeted with a certain amount of enthusiasm. Do you see that as a model you could replicate to other disease areas? You create this data, you start saying, okay, these are, points where we can intervene, maybe not too expensively as well, and help reduce some of those gaps between member states, but also within member states as well.
I mean, with the cancer, we had the advantage that several countries, or many countries, already had national registries and even regional registries for many, many years. So it's something that was advanced. So we had to collect on all that and also encourage other countries to collect the data because, I mean, will be easier for the mortality, but for the morbidity, it's not so always so evident. I don't know if it's a good idea to have registries for every single disease. Maybe we can group them, or I don't know. But this what we are trying now is to have a model of what could be done. I mean, and the usual cancer registry.
Is there a disease you think, or a disease area where you would think maybe the path you've chosen with cancer could be replicated? Cardiovascular, for example.
Cardiovascular is something that already exists in several member states, so maybe will not be so difficult for some areas of cardiovascular disease. And this is not for everything. For the communicable diseases, where it's not a registry, what we have is the declaration of the diseases. They are has been mentioned, for example, for migrants and communicable diseases, we have the problem of, we have a legal problem. That is or a legal issue or a legal background, or however you want to name that. That is the impossibility of collecting data about ethnicity, of country of origin, etc. in some member state. I mean, and it's something that I have been saying for many years. There are countries that
so well-intentioned legal protections are getting in the way of data that would actually help those migrant populations.
Could be, but we have to remember that we come, I mean, that we are in a continent where people were killed before of your ethnicity.
There might be good reasons why those legal protections
are. So this is our history. So in some legislation of member states, I mean, after discussing that for many years, in 2017, I requested the DG Justice to do a study of the situation on the member state regarding the legality, and we did that, and we could demonstrate where is forbidden or against the law, let's say like that, or is in not very clear to collect the data on ethnicity and on migrant status.
I wanted to pass the floor to Anka now. If I could just ask you to respond to Isabel, do you see eye to eye to what was said so far? I'm also going to go get the iPad so the audience can.
Thank you. I'm aware of the barriers that you mentioned, Isabel, and I was wondering as I was listening to you talk about both to you, Dennis, and to you, Isabel, about the lack of data on migrants and particular vulnerable populations, and my wonder would be what we saw, and I have some data here, in the European semester cycle, the last one. It highlighted that many patients still cannot access high-quality healthcare on time, and they suffer from, according to our members at least, they suffer from long waiting time and out-of-pocket payments, which many cannot afford. And that still happens in Europe in a universal healthcare environment. And we saw yesterday in a session that the WHO Observatory presented data that showed that in some country you have ruinous healthcare spending, ruinous, catastrophic healthcare spending, and up to 10-15% of, so impoverishing or making poverty worse. In some countries as high as 10-12%. And this isn't universal healthcare society, in a society that is based on that. So my question is, must we wait for the data on every single population to act?
Right.
I mean, Professor Marmot has been studying. We have data by socioeconomic status. We have data by education status. We have data by age. Must we wait for every single granular data to start acting and to start having an effect?
Well,
because what we see is people are suffering.
So, since you ended with a question, maybe rhetorical, but a question nonetheless, I'd like to put that to Michael. Do we need to wait for the data? do we need to start acting? Obviously, ideally you do both, but where do you see the priorities at the very high level, and which parts of the government and the EU should be acting on health equity? Because I imagine it's not just the health ministries, it's also the finance ministries and other parts of the government. So Michael, if you want to answer that, and also if anyone in the audience has questions, just raise your hand and I'll call on you as well. So Michael, over to you.
Well, the discussion about access to healthcare is vitally important, no question. And even in European countries that have good equity of access, we still have inequities in access, and we need the data. But I've been saying all along, it relates to research and monitoring. We don't wait until we've got every last bit of data. Where we know what the problems are and what needs to be done, we need to be acting at the same time, putting better data systems in place and acting. My general point is that we can't leave the solution of health inequalities simply to health care inequalities because of the crucial importance of social determinants of health. And that means acting right across government.
Well, just for the audience, what's an example of a social determinant of health? Just a very basic one.
Well, let me give you the six. I'm going to give you all six that I had in my 2010 Marmot review. Number one, give every child the best start in life. Number two, education and lifelong learning. Number three, employment and working conditions. Number four, everyone should have at least the minimum income necessary for a healthy life. Number five, healthy and sustainable places in which to live and work. And number six, taking a social determinants approach to prevention and lifestyle. We've got those six. They form the basis of our European recommendations as well as our English recommendations. We know what to do. If child poverty goes up, that will impact adversely on child health and on their chances through the life course. We know that good services to support families and children can mitigate some of the effects of child poverty. Education, equity in access to education. We know that, if a Minister of Education says, why should I be concerned about health? That's not my job. My job is making sure kids get something out of school. And my response is, yeah, pay attention to equity in educational outcomes, and then you are paying attention to health equity, because one of the key drivers of health inequities is inequities in the outcome of education.
Michael, I have a question, sorry to interrupt, but just on this topic, I just got a question from the audience this minute on relating to childhood social determinants, which is the government announced it's rowing back on its obesity plan, the childhood obesity plan. This is the British government. Is that the type of policy that exacerbates health inequality?
Well, so that's what I kind of mean by taking a social determinants approach to prevention. What we know, if you look at childhood obesity, it's given the example of the UK, that the rise in childhood obesity has slowed now for children coming from more privileged backgrounds, but is continuing to rise for children coming from less privileged backgrounds. And people who don't understand anything about anything saying, how can there be a problem of poverty if kids are putting on weight and are overweight? I say that to ask that question means you don't understand anything about anything. Because if you're in poverty, you get the cheapest calories you can find. And the cheapest calories you can find tend to promote obesity. They're not good for health and they're not good for obesity. So what we need is a broad social determinants approach to deal with childhood obesity. Part of that is not making junk food more economically attractive. If you make junk food more economically attractive, then people who are in poverty are going to buy it. So we need to deal both with the poverty and the cost of supplying nutritious food.
Isabel, is this on the Commission's radar? Both the specific point about junk food and how we shouldn't make it cheaper than healthier food, but also this broader social determinants of health approach.
I mean, you know that we have been working on social determinants of health for many years, and also we have been working on food in the previous years with the platform that we had, and then with the different strategies on food safety and others. We know that many actors, many determinants of health are outside the health area. I mean, this is very old in public health, and that we can act on some of them, and for others we need to be in collaboration with other ministries, with other services in the Commission, but each country has to do the same thing. We know that education, social, economic background, and etc. has an impact on obesity or in the outputs that you have for your health, even for the life expectancy. There are areas where it's easier for us to act, and areas that are a little bit out of our competencies, but that we don't withdraw with that. We try to collaborate with the others on that. There is also some issues that are not. That are social determinants also, and that is where you live. I mean, we know the differences between access and as a consequence to the results. If you live in the cities, or you live in a rural area where you need to do, I don't know, half an hour, 1 hour, 2 hours to go to for the treatment to the hospitals, and at the end you can say, stop, I'm not going to do that because it's taking all my life, and maybe I will be better, but I'm not sure at this moment. So there's a lot of different.
Great. So I love that you brought up this rural-urban divide and how difficult it is to access very basic health care for many people all throughout Europe, even in the wealthiest countries. Iceland, Norway, these are places that are very rich, but that if you live in a very isolated small village, your health suffers as a consequence. I'm going to ask the panelists to sit back down. We're going to bring you up again at the in our third panel discussion, so we will return to you. But right now, I'm going to be joined by Caroline Costings of Euro HealthNet. Caroline, maybe actually you sit there and I'll sit here, and that way we're nice and central. And I'm really excited to talk to Caroline because she's a doer. She's in the thick of it, helping coordinate health experts all around Europe, seeing what works, seeing what doesn't when it comes to improving health outcomes right across society. But before I speak to Caroline, I did want to introduce some research produced by the session partners, Porter Novelli. And this is a survey conducted among 460 healthcare professionals and 75 payers between July and September this year. And the topic is health equity and pharma. 76% of all healthcare professionals agree, and 38% strongly agree that pharmaceutical companies have a responsibility to help overcome health equity challenges among critical patient populations. And more than half of respondents believe it's very important for pharma to prioritize partnership and system collaboration. So we're going to return to those points later, and we'll have someone from the pharmaceutical industry talk about it. Caroline, thanks so much for joining us today. A first very simple question. Are there any obvious practical measures, and since we're operating in a resource-constrained environment, inexpensive health equity solutions that governments are ignoring at the moment?
Yes, thanks a lot for the question, and I must say I'm really pleased to see how equity has become such a central theme here at the Gastein Forum, and also how this session, sponsored by private industry and private actors want to get engaged in that debate. So I really appreciate that. And yeah, there's a lots of practical solutions out there that we need to further work on. And maybe referring to two themes that are already mentioned in the first panel. The first was on the cost of living. You may have heard that after 2 years, now finally, earlier this month in the European Parliament, they now have an agreement on a minimum wage, which is super important if you want to get a living, healthy living costs. And also the Commission is putting forward a recommendation on minimum benefits, which is very important for people. And again, on in terms of income, the catastrophic health expenses that many people are facing is something where we need to advance on, and this is where the Commission, again, with the pharmaceutical strategy, can take forward, and it also needs to be put much better in the follow-up of the Oslo medicine initiative.
This is going to get worse with inflation, obviously.
Exactly.
I mean, the cost of living crisis.
Yeah.
Yeah.
And I wanted to add that now with the green transition and the mitigation measures to combat climate, of course, they will have an impact on vulnerable groups. We have seen in France the yellow vest movements. But now in France, they have this interesting solution that they are taxing carbon use, so taxing the polluters, but the income that they get from tax is going to the poorer people so that they can also be supported and therefore somehow been taken into consideration into these climate change mitigation measures. So,
right.
So, yeah.
Yeah, so before we go into our panel discussion, I did want to ask one thing. Brussels is prescribing museum visits for mental health, yay or nay?
Yeah, yes. I think that social prescribing is definitely a very innovative and interesting way how to bring the social determinants into health systems, because it is making and it's making use of the resources that are out there in the communities. It is making doctors see what non-medical treatments they can prescribe for non-medical problems, but even though that has an impact on ill health. And in particular working with the communities and with the solutions in the community, that's where you can make the connection to the people that are suffering, that are lonely, that are not able to engage and therefore deal with their problems.
Great, well, thanks so much, Caroline. Stay on stage. I'm going to ask Alexandra and Ricardo to join us, and we also have a multiple choice poll, and you can answer on Slido, and the poll is, do you think strategies to reduce health inequalities should be focused on community, country, or disease? So you have to choose one of the three. We're going to get the results behind us. Audience in the room, I'd like all of you to think of some questions, because so far I've only taken questions from Slido. So please just raise your hand, and when I have a second, I'll take a few questions from the audience and throw them up to the panelists who are here. So far I'm seeing that over 90% of respondents are saying that strategies should be focused on community, so that suggests a more granular approach and maybe more intersectoral approach than either country or disease. Panelists, do you have any thoughts on community versus country or disease? No? Okay, well, we'll return to that. Ricardo, I'd like to start with you. You're the founder of the Unite Network to End Infectious Diseases. A very simple question. Can you just tell us about that work?
Well, hello, and good afternoon to everyone. It's an honor to be with my esteemed friends on this panel. It's an interesting question that was posed here, and it connects with your question. Unite is a global network of members of parliament, congresses, and senates from around the world. We're representing now more than 85 countries, focusing on global health matters. And I personally am a fourth-term member of parliament in Portugal at the national level. I have this role as an NGO at the global level. And I was also a deputy mayor in my past, along with my background as a medical doctor. And so I've seen it from multiple angles. And the right answer here is yes to everything. And the truth is, inequalities need to be addressed at the global level. When we talk about, we talked about this morning on how GDP is pushing us all in the wrong direction. And macro measurements can actually lead to greater inequalities because we're leaving the margins of society behind. We're not focusing on inclusive growth and well-being. But even at the local level, when I arrived as deputy mayor at my city, 200,000 inhabitants, what we noticed was, and Anka raised the issue, we're always waiting for more data. But let's look at the data we have. And what we did was we geo-referenced all the health, educational, and social data that was available. And using georeferencing, we started to see phenomena coming out that nobody really looked at because the global indicators showed that everything was okay. But actually, there were parts of societies being lost behind. And coming from infectious diseases, I went through medical school without really understanding. We're with Sir Michael Marmot. At the beginning of his book, The Health Gap, he reminds us how he understood the importance of social determinants right as a medical resident at a very young age. I felt another phenomenon which was dealing with HIV patients, and Dennis rang a bell on this, on how HIV patients are many times at the margins of society. And so as politicians, be it at what level we may be, we need to be conscious that when we talk about universal health coverage, it's more than just this general concept of ensuring healthcare for all in theory, but it's making sure that NGOs, patient advocates, those that represent the most frail parts of society, those in most vulnerable situations are part of it, or else universal health coverage will fall short.
Ricardo, I wanted to get your perspective of someone who's in the thick of it, but also a politician and has that kind of political mindset as well. In a very practical example, which is COVAX and the COVID-19 vaccines, in your opinion, what went wrong there? I mean, I know that this session is focused on European health equity, but if we zoom out for a bit and look at global health equity, what lessons are there to learn from that?
Well, I think the first thing we need to acknowledge and be honest, and coming from HIV, I'm very sensitive to this issue, is that if COVID-19 had been a global south disease, we wouldn't even have a vaccine today. The only reason why we have a vaccine is because it affected more significantly the global north. North America, Europe, the richer countries of the world were the ones that were affected, and that led the industry to work with governments, and the money was poured in until we got that vaccine out there. COVAX, I think, actually brought some interesting results, but it goes to show that developing a solution in the midst of a crisis can lead to negative outcomes or not as positive outcomes as one would wish. So I think the lesson learned here is that when we talk about pandemic preparedness and response, we also need to talk about pandemic prevention, preparedness and response. And so being capable to have the mechanisms in place at the global and local level to make sure that we stop outbreaks before they become pandemics. And in the case we have a pandemic becoming a pandemic, that we have the mechanisms already in place capable of responding, which means, and I always use the NATO example because I think it's a good example of a coordinating body that coordinates efforts, but at the national level, each country has its own mechanisms in place and they're constantly doing simulation games. In each country around the world, even in the richest countries, we are not simulating on a constant basis. We do not have teams allocated exclusively to pandemic prevention, preparedness, and response. And having mechanisms like COVAX need to be prepared and oiled up on the logistics side, on the distribution side, so that if a crisis comes about, they are capable of responding.
Thank you, Ricardo. I mean, you've really put the question in my head now whether anyone from COVAX has ever spoken to someone in NATO, two very different worlds, but somehow parallel. But Alexandra, I wanted to move over to you next. I mean, pharma, whatever you think of it, obviously they're just such a key part of any solution. And I know that FPA records very good data actually about pharmaceutical access inequality throughout the EU. First of all, what does your data show? Where are the pain points? Where are the inequalities worse in the EU when it comes to medicines access?
Thanks so much, and hello everyone, good afternoon. Thank you for the invitation, thank you for the opportunity. Indeed, when speaking about gaps in access and inequalities in access, we do like to refer to the data, to the measurements that we've done. FPA conducts an annual survey, the patient weight indicator, really tracking the time it takes from approval, authorization at the central level of a medicine and when it reaches the patients. And we do see a huge gap between, let's say, Western countries like Germany, where it takes around 120 days for a medicine to reach patients, and a country like my home country, Romania, where it takes more than 800 days for that medicine to reach patients. And it's not just the time, but it's also the amount of medicines that that reach patients. So Romania, it's only 1 in 4 medicines centrally approved that really make it to be reimbursed. So 25%. That's quite a challenging and worrying figure for our industry. That is an industry that develops medicines and really wants to bring to the market innovations that don't sit on a shelf but really reach patients.
So, Alexandra, I'm now going to give you the difficult question. FPA records such, great patient access data, but I also know FPA is opposed to moves to require pharmaceutical companies to launch in all EU 27 countries within a certain amount of time. I know that you've done a voluntary commitment that you'll do that within 2 years, but why do you oppose mandating it if that would be one way to reduce inequality?
I would say that we are concerned about imposing on the pharmaceutical industry measures that are not under our control. So it's not about mandatory launches because, as you've mentioned, our industry has made a commitment and our members have made a strong voluntary action to launch medicines, to make them available within 2 years in all member states after being authorized at EU level. Our concern is about linking the protection of our clinical data to this launch in 27 member states. So the fact that there will be a disincentive for the industry connected to measures outside of our control is something that we are concerned about, and we want to bring additional evidence and data that policy intervention will not lead to the right solution.
Okay. Thank you, Alexandra. I'd like to take some questions from the audience in the room. Can you please raise your hand? Yes. I will I see someone bringing you a microphone. And if you could just state your name and organization and then the question.
Yes, thank you. I'm Joris Linsen. I'm a Dutch master student at MCI Innsbruck. I hear that creating equity in the pharmaceutical industry is very high up the list of your priorities. How far are your members willing to go when it comes to reducing profitability to create a better equity among countries like Romania?
Thanks so much. So indeed, we've seen the data that was conducted, the research that was conducted, that there is a request from the pharmaceutical industry to support health, the more health equity, and I think we have shown that our industry is willing to step up, both in crisis, but also in peace times, let's say. So our industry has stepped up and delivered in record time vaccines for COVID-19. And if we look at the social benefits of these cross-industry collaborations to deliver vaccines, it's around $70 trillion, when the private benefits are only around 80 billion, right? So it's a factor of 1,000. And then also when it comes to another crisis and war, actually, Ukraine, our members have made significant donations, financial donations, but also medicine donations to support refugees from Ukraine. So we really look at where is the need and where is the crisis and how we can step up. But also in non-crisis times. So our industry, and we've mentioned the commitment, but it's also about maybe a broader action around looking at the right pricing level for each country. And we have proposed and hope to engage in a conversation about equity-based tiered pricing so that our industry can offer medicines depending on the budget.
Right. We have two questions from the audience, but before we get to those, Ricardo wants to jump in real quick.
I can't resist, sorry. Because I think it was an important question about putting the pressure on industry to reduce profitability. And in the European context, of course, we all agree that that has to be part of the solution. But it is also the responsibility of governments to play their role. And the fact that most governments in Europe are not willing to have joint procurement leads to the fact that the choice to define the tiered pricing, who pays more, who pays less for the same technology within the same union, is up to the industry. We give up our important role as leaders of the countries, as elected representatives, to the industry, which makes no sense. We would not accept this in other contexts. And so there has to be courage starting from the richest countries in Europe, which are the ones that block most joint procurement efforts, to understand that we need to have a joint effort towards equity that starts at that level. That's on the first point. The second point is, with the money we are currently spending on medicines and health technologies, since we do not measure the value they bring, we are blindly paying for decades. We have no idea what we are paying for. The industry promises based on medical research certain results, but then we are not measuring, which means we are paying for good technology, but we are also paying for bad technology that is actually leading to a deviation of resources, creating waste and not treating our patients the way we could. And so this is also a political issue that needs political leadership, and we should not just wait for the industry to come up with the solutions. We as the people, we as the representatives, we as the political leaders have that responsibility too.
Thank you, Ricardo. Yes, it's easy to blame industry, but national governments have their responsibilities as well. I wanted to get those questions from the audience. Yes. If we can get you and then Elizabeth up front, we'll take both and then pass them.
Yes, and I think I'm going to follow up very briefly on this answer. My name is Clara Volintiro. I'm a professor of economics from Bucharest, Romania, and a governance consultant for the World Bank for over 10 years. And my question portrays exactly to the pressure that the EU and national governments can have together on reforms. So you mentioned pressures on the industry, but I would like to mention pressures on reforming healthcare systems in Eastern Europe and your member states. Does the EU, and this is a question to Caroline and to you, does the EU imagine any sort of additional conditionalities for healthcare reform in order to provide equity and to proceed with the European Health Union?
Okay, so conditionalities on healthcare reform. The Health Union, Elizabeth?
Yeah, well, thank you so much. My name is Elizabeth Kuiper. I'm leading the Social Europe and Wellbeing Program at the European Policy Center, a Brussels-based think tank. And the observation I wanted to make is that what's, in my opinion, absent from the discussion is that the climate crisis is very much leading to health inequalities as well. I mean, we've seen it all this summer with droughts and wildfires, even some infectious diseases coming up. And in terms of indeed the need for healthcare reform, I think more prevention, and the fact that I think throughout this conference we're now discussing what kind of crisis do we need more. I mean, it was actually the European Policy Center that coined the term perma-crisis, but we have so many crises. So do we think that's actually leading to more momentum for a better, let's say, healthcare spending? Do we feel the momentum is there, or what do we need more?
Okay. Yes. So Caroline, I'm going to throw both of those questions at you, one after another. I feel like they're related as well. So the first one was around conditionalities in the European Health Union, and the second one on perma-crisis and creating momentum.
Yeah.
Thanks, Elizabeth.
Well, the Commission is not about reforming of healthcare, because obviously that is a national business, but they are very much concerned about the sustainability of health systems, which is very good. And I must say the country-specific recommendations that have been given to countries as part of the European semester on the healthcare reform, they were strengthening primary care, stressing public health also in the community setting, and that is a measure that I think we need to move towards, referring
So prevention,
to prevention.
care.
Yeah, what Elizabeth was saying, prevention.
Does health education fall into that?
Yeah, health education is one little part of it,
Sure.
but definitely prevention as NCDs. You were talking about infectious diseases, but NCDs is a big problem. If you look at the social gradient, it's particularly people in the lower bottom of the social gradient that are suffering from these diseases. And as Michael Mahmoud was saying, that has an impact on their jobs, on their education. So prevention of NCDs is an area that we need to move into. And there are very good examples already out there. If you look at Slovenia, they have a very strong network of primary care centers and health promotion centers. So really, disease prevention, health promotion are very well integrated with community nurses. In the Netherlands, for example, the health insurers, they pay for people visiting well-being coaches. So it's all integrated now into the healthcare system, and it is very much also the personal approach with well-being coaches that helps people forward. And it also makes economic sense. There's data from the US that states that the return on investment in community health workers is $2 for every dollar invested.
So just to give people an image, what is a community health
worker? A community
worker?
health worker is someone who knows the problem of their community, goes to visit and outreach to people that are in need, give them support in terms of health, mental health, and other activities. So very much the...
So a health union could also mean dispersing health professionals throughout the territory to provide this combined social and health services in rural locations as well.
Yes, exactly. And I think for the future, we need to do much better in bringing the health and the social policy sector together, because it's still too far apart from each other. Health sector is there, social care is there. Also at the European Union level, we have the European Health Union, and we have now a beautiful European care strategy, but they are totally unrelated. Well, I see that very much more joined up, and I think that is one of our challenges for the future, is to see, okay, how can we develop that area in the middle with sufficient resources, workforce, and support in innovative ways. And here is also where the private sector could contribute to, for example, to calculate the return on an investment and to see, okay, how is it profitable and how can we make savings elsewhere, because we are investing in these social health combined new initiatives.
Great. Thank you so much, Caroline. With that, we close out this section of the panel. I'm going to ask you to stay there, and I'm going to invite all the other panelists back on stage. I'm going to sit at the podium. And I will have another one-on-one conversation with Michael, if we can get him to appear up on the screen. There we are. So, Michael, in this final segment of the discussions, we've been discussing the theory of health inequality. We've been discussing drivers of health inequality, and we've been discussing some practical examples of health inequality. But I'd like to draw some conclusions and throw the discussion forward towards those 2030 development goals. what do you see as the way forward to reducing health inequalities and reaching out to some of those hard-to-reach populations, undoing some of the negative social effects of deindustrialization, for example, and the emptying away of countrysides all throughout Europe? I guess, like, what are our high-level goals going forward?
Well, please allow me to say three things. The first is that I would like to see all governments put equity of health and well-being at the heart of all policy. We've heard a lot about environmental impact statements. We should have health equity as a consideration. You challenged me about the UK government. The new Prime Minister hasn't mentioned health virtually at all, and she said she's against redistribution. She thinks talking about redistribution is wrong. Set the rich people free and then everybody will benefit. It's garbage, but it's very important that you say, no, this is not marginal. We put equity of health and well-being at the heart of all government policy. The second, and we've been doing this in the UK, but it's been happening elsewhere, and you touched on this in an earlier session, where national governments are not acting, but also for positive reasons, we can get action at city and regional level. It doesn't need to wait for national government to act. And in fact, the eagerness, the willingness, the commitment to act is often much greater at city and regional level or district level, because for the local politicians, that's where people live and work. They understand the realities of life. And the third that I wanted to say is to pick up on your discussion of the pharmaceutical industry. And I would generalize it. We did a report recently, earlier this year, The Business of Health Equity, the Marmot Review for Industry. And we said that industry has a role to play. In public health, we've always seen industry as the enemy. Smoking, junk food, and the like. But we said that industry has a very important role to play. First, in employment. Do they treat their employees properly with paying conditions and the like? Secondly, and it relates to what was said about the pharmaceutical industry, goods and services that can improve health or they can damage health. They can improve health equity or they can damage health equity. So that's absolutely key. And the discussion you had about pricing is very much related to, will your products improve health equity? And the third, we talk about healthcare as being anchor institutions, industry as having a wider impact on the community, on the environment, their purchasing decisions and the like, can all have negative impacts on health equity or positive impacts. So those three, national governments putting equity of health and well-being at the centre, encouraging local action, and third, bringing industry as positive players to promote health equity, I see as important ways forward.
What do you see as the cost of failure? If we don't integrate health equity into all policies, what does 2030 look like in a more health unequal world?
I've resisted all the time, from the time of chairing the WHO Commission on Social Determinants of Health, putting a monetary value, a dollar or euro value on it. A lot of people have said, yeah, look at the cost of untreated health inequalities. Yeah, I'm sure they're enormous. And occasionally we do cite it. The cost is immorality. The cost is, we talk about health equity because it means that health of disadvantaged people could be improved, but is not improved by reasonable social action. And that's immoral, that's unjust. So the cost is avoidable health inequities. And that's an enormous cost, not a dollar or a euro cost. That's a cost. What do we want societies to do? Ideally, we want societies to create the conditions for good health for all the members, not just the privileged. So the cost is potentially enormous.
Thank you so much, Michael. That concludes our one-on-one discussion, but I ask you to stay online for the panel discussion. I really want to encourage the audience this is your opportunity. You have all the panelists here to ask your questions. Do we have any questions in the room first, or else I will proceed with mine? Okay, none yet. Well, I wanted to ask a first question to Alexandra, actually, which is, we've been discussing the industry and the industry's role in tackling health equity. I was curious to know, you represent the branded pharmaceutical industry. When it comes to the social components of health in particular, what do you see your role in that? Is that a totally separate bubble from you, or are there points of interaction on those social determinants as well?
Yeah, thanks for the question. I think FPA and especially our members are very happy to support some of the initiatives, so the Nobody Left Outside initiative, and partner with stakeholders. I see from the study that there is also a request from the respondents of the study for more partnerships and collaborations. So our industry is very open to have more partnerships and work towards ensuring health equity. We traditionally have been working on co-creating solutions. So we partner with patient organizations and have invited stakeholders to join some of our initiatives around tracking unavailability and delays in access. So there is that openness from the industry side. And also the openness, and 1 in 6 of us panelists would like to see more evidence around value of medicine. So there is that openness to work with healthcare providers and national governments to have real-world evidence, real-world data around medicines. And we have been supporting initiatives around HTA and the joint HTA, joint clinical assessment, and then tracking value at national level. So there is that openness. It's just we want to be a partner at the table and welcome that. Great, thank you. We have a question in the audience. I'll take a few questions at once, so if anyone else has a question, yes. So if we can get a microphone, or, yeah, thank you. And yes, please go ahead.
Thank you. This is a very exciting discussion that's going on. My question is to deliver this ambition, to what extent are we actually acknowledging the fact that there is a gap in knowledge about the real issues? Say, for instance, I walk down to the Commission's European Commission in Brussels. There are people sleeping in the street, right in front of the Commission's place. I mean, homeless people. So are we actually understanding that these are things that are happening right in front of our faces, and those who are in the position to make the decisions that will have this impact on equity across the board is recognized?
Thank you, thank you. And can we get the second question as well? Yes.
So hello, I'm Montanas. I'm representing European Junior Doctors Association. So maybe I'll address the question more to Ricardo, who's like representing members of parliament who are mostly dealing with the healthcare problems. So we discuss here a lot about health inequalities in terms of really marginalized groups. And also we kind of address the problem with pharmaceuticals, to like faster access to more and better drugs. But my question is just like whether politicians actually who are responsible for healthcare in general, even in the countries with universal healthcare in theory, actually assess and evaluate how well we protect financially people. Because even in European countries, you can get some, in some cases, like 30% of healthcare spending is out of pocket. And whether you're actually trying to address that problem, that how we can protect the lower income people rather than, trying to solve one particular problem, but just restructure the way how we finance care and how we tax people.
Okay, great. So we have 2 questions here. The first one is about making sure that our discussions about health equity aren't just abstract, homelessness is real. And I'm also taking a question from Slido. I'm going to combine the two. The EU Commission launched an EU homeless strategy in 2021. And, homelessness obviously is associated with poor health. How will DG Health contribute to the strategy concretely? So I guess, Isabel, if I can ask you to take that question about homelessness. I see you shaking your head. You're not happy about it. Do you want to give it a shot?
I mean, I'm not happy because I know what is behind, and I was already in that trap in a meeting some months ago. But the Commission and DG Santé is working on all the different strategies that the Commission has established that are for many different groups of the population. And as I said before, we have specific strategies like the cancer or the healthier together, where inequalities are taken into account. And then also other strategies that have been established for different groups of population. So we are doing our best. I think that we are transparent in our actions. The Commission works with the stakeholders. We work with the Council. We work with the Parliament. All of them, I mean, we have our different responsibilities, and everyone has his say. And we are also working specifically in DG Santé with the thematic networks, where health inequalities has been for a long time one of the topics, and this year is again one of the main topics, and where some of you that are here, I mean, are leading or participating on these thematic networks that at the end. I mean, they are working with the associated, but they are also telling the Commission what we will need to do, where we will need to improve, and which issues are not really responding to the requests of the civil society. So that I think that we need all to collaborate. And yes, I reiterate that DG Santé is working with all the different services in the Commission in the different commitments that the Commission has taken.
And Caroline and Dennis, in that order, do you want to answer this question about homelessness as well?
Yes, I wanted to recall to you that we had a joint action on health inequalities, and they had a specific work package on migrants, so not particularly on homeless, but on migrants, where they did a lot. Various member states, like in Portugal, Italy, and Spain, they worked on some services and trainings for health professionals, how to deal with migrants, how to understand their needs, and how to be sensitive to the needs of specific groups, which I think is very important. And I agree with you that many groups fall under the radar of politicians simply because they are not appearing in statistics and in the data. So indeed, there is not a full understanding of what's happening. But I also feel that we need to make sure that all of the various groups are part of our universal policies and measures. We do not want to deliver, let's say, poor services for the poor, and that is the risk that we have. And we have a risk of stigmatization and to even confirm the marginalization, while it's the comprehensive approach, I think, what is so important. And I know that Michael Mamet is using the term, what is universal proportionalism, proportionate universalism, which I think is a very important principle.
Dennis.
Yeah, I'm sorry. I just wanted to raise the issue of, I think, representation. And thank you very much for that question. We see a situation where the voices of marginalized communities are not heard simply because they are not represented at the right discussion forums. So I think that needs to change. Especially as we address health inequalities, we need to look at whether we're looking at healthcare professionals, the industry, community, we should be able to have co-production of policies that are inclusive. I also feel that, one of my colleagues actually from NLO observed that DG Santé does not have health inequalities amongst its priorities, especially as far as marginalized populations are concerned. So maybe Isabella will address that. But I think that what I think is important is that we should acknowledge also the role of the industry, because as somebody who's working in the community, my experiences of funding of health program, the way funding works is that it's a cycle. So, you get services commissioned over a long period of time and they kind of not change. But what the industry has allowed us to do is to be able to innovate continuously. And I think that should be acknowledged, especially at the level where we work. I think that's really important. But on the issue of sensitivities, trying to have systems that are sensitive to people's needs, one of my colleagues at NLO noticed that 50% of trans people experienced discrimination in healthcare settings in 2019, according to a 2019 survey. I think that should be addressed. We still have sex workers being criminalized, policies across Europe that are really criminalizing sex workers. There's lack of social protections. I think that, including communities in these discussions around the tables. When you go to Brussels, I think these communities are not seen. So we should have them around the table for us to be able to have functioning policies.
Great, thanks so much for that, Dennis. I did also want to address the out-of-pocket healthcare costs. That's one for you, Ricardo. I don't know what the situation in Portugal is when it comes to out-of-pocket costs, but it's been brought up quite a few times. Obviously, in times of inflation, in times of a cost of living crisis, it is a topic that is on people's mind.
It's a huge topic, and it's been going up and up in Portugal. It's over 30% right now. But taking a step back, feeding from the homelessness question, there are risks related to big data, right? And the fact that you can have a European policy on homelessness, you can have a national policy on homelessness. My experience at the local level, you have to deal with it locally. On a weekly basis, as a deputy mayor, we had the stats of how many homeless people were still out there and what was their social situation, and we had teams working with them and dealing with the mental health issues and so forth. You need to go local if you want to solve the social inequity issues, as Sir Michael Marmot said. I mean, being here on stage also with Michael Marmot always breathing down our backs really puts the pressure on. We should get him after politicians around Europe that could get things getting done. But that brings me to out-of-pocket then, because I was talking yesterday with Francesca Colombo from OECD, and I was telling her, I'd love to see a study on the potential out-of-pocket. And she said, what do you mean by that? And I mean, especially as a crisis steps in and as people get poorer, you see out-of-pocket, which is really what people pay more on top of their taxes to get access to care. But as people get poorer, they would actually spend more if they could. And the truth is, the inequalities and inequities would be even greater to show. But it's impossible to show because the data is not there. But empirically, it is very clear that when a few years ago, thinking, we were in Europe very proud, nobody would become financially bankrupt in Europe if they got sick, unlike the Americans, right? That was something we were proud about.
Yeah.
Not anymore. And many countries, my own included, you can become financially bankrupt if you get sick. There are technologies that are only available in the private sector that you have to pay out of pocket if you have cancer, certain types of cancer or other diseases, because they are not available through the National Health Service anymore. This is a major form of inequality. The last thing I want to address is on moving forward then on a more macro scale, because it was raised, I think it was Catherine, on climate and housing and all these other issues and poverty. How do we keep pushing forward? And we have all agreed on the Sustainable Development Goals. We are lagging severely behind, and we're halfway through, 7 years to go until 2030. And so what we did at my city, once again going local to solve these issues, was we transformed the indicators that are global indicators to local indicators. We created a dashboard. So every year, when the city has to discuss the budget for the next year, we can actually see where we're lagging so we can reallocate resources. But what was interesting was when we created the dashboard, my city was considered the most advanced city in terms of clean energy and energy efficiency. And when we looked at the dashboard, it was where we were doing worse. So we won all these prizes, but nobody was looking at the data. And we fool ourselves because of the gimmicks that sometimes are put out politically. And the mayor was very courageous, but he put the data out there, and he went to show we don't care about the awards, we care about what is happening with the people. And I think this kind of local leadership can serve as an example. And what we would expect, and just to end here with what was the question on the World Bank and the role of the European Union, I believe that, Carolyn, you're absolutely right, it's a national competency. However, if we were to standardize healthcare indicators in terms of value and be able to compare countries, this would be a huge motivator to push countries to move in the right direction if those indicators were to focus on well-being. The only thing health systems are really good at measuring is dead bodies. And we need to make sure that we measure indicators that focus on quality of life, on well-being, and compare countries so that there is a positive incentive within the union so everybody can go in the same direction, in the positive direction.
Well, Ricardo, please, yeah. Before I go on to the next panelist, there's just two things I wanted to pause on there. The first was the fact that you can now go bankrupt in Europe because of out-of-pocket healthcare costs. I mean, that's something I never even thought of. It's something I'd associated with dysfunctional health systems across the Atlantic, quite honestly, but now it's a reality in Europe. The other thing I really liked was this idea of a dashboard as a kind of solution, or at least part of a solution to addressing health equity, because that's such a concrete example of something that local communities can all do, start creating these kinds of repositories of data and visualizing them. But Anka, I wanted to go over to you next. You know, we've been talking about solutions, and I want to stay on that path. From the patient perspective, and you know, I know maybe patients aren't always the ones entrusted with coming up with solutions, but I was curious to get your thoughts. Are there any big solutions from the patient perspective looking on to 2030?
Well, you see, here's the problem. You said patients aren't always entrusted with finding solutions, and that belief is actually one that we must change, because in the end, patients are the recipients of health services. We are the users. Our members are the users of health services. It all starts with social determinants of health. Access to prevention has the same inequalities as the access to care, to services, to products. And patients are treated just as the objects of healthcare. We have to become active participants in healthcare. So I cannot believe that I'm adding one principle to what Professor Marmot said. I never dreamt that would ever happen. Hashtag fangirl. But a fourth principle, after equity at the heart of all policy, act at the most appropriate level, involve industry, involve people, involve civil society, work with us, ask us what we need, build needs-based systems and not, tweak around the edges. You know, if you're going to put equity at the heart of your society, then you really need to demolish, okay, I'm not going to go revolutionary, but you really need to put it at the foundation. And how can you build equity without asking the people for which it is made? So, first challenge, we should be part of, from a patient perspective, yes, we should be part of the solution. And we are doing some work, and we've been pulling the alarm on access, on out-of-pocket for years. We are asking our members, we're asking patients, how are they affected now with the COVID crisis? I guess maybe we should be asking them also how, and I absolutely dread the result of a survey on the pricing crisis, on the inflation crisis. And what we see is access to care, access to services, access to medicines is declining. So we have some data too, and we have experiences, and we are working, actually the best, we work with private partners in bringing the patient experience. We would absolutely love to be talking to governments everywhere to propose solutions.
Great. Anka, thanks so much for that. I see that Michael wants to respond. We're over time, but Michael, please close us out, and then we'll go to the final poll and the discussion, please.
Well, 2 comments. I take Anka's point completely. When we talk about local level, it's not just local government. It's the voluntary community and faith sector, the police, education, fire and rescue service, and community groups. Vitally important. So I underscore it, very important. Secondly, I often do, speak as if there's somehow a division between healthcare on the one hand and social determinants of health on the other. We're now working to try and break down that division. Caroline mentioned social prescribing. We're working with health and care systems to try and get them active on social determinants of health, because they recognize there's an intersection between people's position in society, the social determinants, and their access to healthcare and their response to treatment. So it's vital that health systems also address social determinants of health. And that means that we're all united in trying to pursue equity of health and well-being that should be at the heart of everything each of us does.
Thanks so much for that. What a powerful note to conclude it on. But before we let you all out of here, we do have a final poll, which is what else do you need to help you drive the national and local elements of the 2030 health equity ambition forward, a cluster approach of shared learnings? Is it more research on critical needs, more open collaboration, central policy framework design support, central funding, or more innovative collaboration for all sector stakeholders? Okay. Well, this connects perfectly to what Michael was saying just now about, well, maybe he's biased the results slightly, but we see number 1 is inclusivity of multiple stakeholders, although tied with strong leadership from the EU level. That's one for you, Isabel. I want to let all the panelists respond very briefly to both to the poll and just, I'd also like for you to say one target to aspire to and one benchmark to hold yourself against. You have literally 10 seconds each, so really quickly. Dennis, if we can start with you.
So health equity is really about political and social climate. I think that we should prioritize prevention to avoid later costs in the healthcare system.
Thank you.
I have nothing to add to the poll. Inclusivity and multi-stakeholder collaboration.
And the benchmark to hold yourself against.
Well, to participate in all of that, to find the resources somehow to be part of that.
Perfect.
I think the strong leadership from the EU level is vital and going to be super vital also with an eye on the European Union, the European Parliament elections in 2024. It's a bit worrying indeed with now how changes in governments are and with populism, and equity is really a central theme that we cannot underestimate. So we need to act on that, set targets and work together in order to...
And what's your target?
Well, I want to achieve take the economy of well-being forward in all this. So that is my target.
Great,
yeah.
Thank you.
Well, I agree. I mean, well-being needs to be front and center. And I guess what we can leave the room is calling on the people to put pressure on their political representatives to fight for this and to make sure that everyone in society is involved, from the patients, from the NGOs, from all different realms of society. Because if we do not do this, we will end up always with the same people, which means that many others will be left behind.
And your benchmark?
In terms of?
just something to be held up against in 2030 to see if you've done your part.
Let's not make it complicated. Let's focus on the Sustainable Development Goals and get the job done.
Great,
Right?
sounds good.
For me, it's very much about inclusivity and coordination, standing behind the best proven solution to tackle health inequalities. So that requires data and measurements and going to the root causes. And for our industry, we really take seriously our responsibility and accountability to delivering new medicines for everyone that needs them.
Great, thank you.
I think that the European Union is showing already a leadership. The European Union is not just the Commission, it's also the Parliament, it's also the Council and all the other institutions. Not having data is not an excuse, but we have data already, and we need data to make potential comparison among the member states and to show what some of them are doing and what can be done. I mean, to share the best practices, we have the State of Health, the companion report, so we are already doing that. We have the instrument to support the member states that are lagging behind the others, and we are doing that now with the Recovery and the Resilience Facility. So, and my benchmark for 8 years in the 2030. I mean, we have many indicators that could be useful, but I think that what we will need is to show that we don't have the inequalities in the things that we have mentioned before: the rural, the cities, the geographical dispersion, the economic power, and that that we were very proud before. That was we were not the United States, and I remember one TV series that everybody has seen, that is Breaking Bad, when the guy goes to the doctor, and the doctor requests for the treatment of the cancer, how much money you have, because according to that I will let you know which the treatment is. We were very proud that before was not that. I hope that in 8 years we are not in the same that the United States.
I love that. Michael, please.
Edit. As my benchmark, I said what I'd like to see, but my benchmark, when we launched the WHO Commission on Social Determinants of Health, we said we wanted to launch or foster a social movement on health equity. And in a way, the benchmark is the more countries, the more cities, regions, voluntary organizations that take up the challenge of social determinants and health equity, the more we know we're making progress.
Great. Thank you so much. Just to wrap up that discussion, I think one thing that came up over and over again throughout that whole talk was the importance of data, the importance of not flying blind, the importance of being able to figure out who it is that needs help the most, but at the same time that we shouldn't wait to create elaborate IT or data gathering infrastructure because we need to act, and we need to act because we are in a perma-crisis, as Elizabeth put it, and action doesn't have to come from the national level necessarily, especially when our national governments seem like they're failing us. It can be regional governments, it could be rural cities and municipalities, but it doesn't even have to be the state. It can be the patients, it can be churches, trade unions, civil society. These are all part of a solution, and that basically we need to act to make sure that Breaking Bad can't happen in Europe in 2030. So on that note, thanks so much, everyone. It's been great to have you here. I'd like to thank Porter Novelli for being such great partners for this discussion. And if you want a summary of today's session and also a full rundown of the data that was mentioned earlier, that payer survey, the link is on the site, and that there will also be a follow-up debate later this year. So thank you so much, everyone.